provide some feedback to our speaker. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered here with the TAFP. Our mission statement is listed there for you. Also, if you are interested in CME credit, you are able to view your transcript at the CME website listed there. I won't waste too much time, so if you have any issues, please contact me if you have any trouble with your transcript. Also, you can receive credit through the AAFP for this presentation. So just please feel free to reach out to me, though I'm happy to help. We also want to make sure that through our FCM Grand Rounds, we do address these nationally established physician core competencies, which you can see listed there. And we just need to mention that Dr. Nadeau has no relevant financial interests with ineligible companies to disclose. Were you going to give an introduction, Dr. Vaca? Okay.
Okay, so thank you, everyone. Thank you, Nicole. So it is an honor for me to introduce our speaker, Dr. Mark Nadeau, today with the topic migraine headaches. Dr. Nadeau is as you may know, is the program director of the Family and Community Medicine Residency Program at UT Health San Antonio. He's a professor clinical for UT Health San Antonio as well, and he holds the Lerner Poe Endowment. He has been a family physician for 40 years. He joined the Department of Family and Community Medicine in 2005 after serving as an Air Force physician for 27 years. He also earned a master's degree in business administration from the University of Massachusetts. So he could teach learners at all levels about the business aspect of medicine. Since primary care is critical to the functioning of our country's medical system, Dr. Nadeau has devoted most of his career to educating residents and medical students. As the program director for the Family Medicine Residency at UT Health San Antonio, Dr. Nadeau has mentored and advised faculty members. He has taught medical students in clinical settings. He has facilitated case discussions for preclinical medical students and preceptor residents. Additionally, Dr. Nadeau has helped the program achieve a reputation for exemplary resident scholarly activity, and he's recognized by the Certifying Commission on Medical Management as a certified physician executive. He is a fellow of the American Academy of Family Physicians and a diplomate of the American Board of Family Medicine. He's currently a member of the Family Medicine Review Committee of the Accreditation Council for Graduate Medical Education, and he is a distinguished teaching professor and a founding member of the Academy of Educational Scholars at the Joe R. and Teresa Lozano Lund School of Medicine. Please welcome Dr. Nadeau.
Speaking of this. All right. Well, thank you, Nancy, for that very generous and warm introduction. Thanks to Nicole and Dr. Falcone for getting this set up. I really appreciate that. Before I get started, I want to recognize that we have a number of outstanding residents with us today and a number of outstanding medical students. So that's the future of family medicine. So very happy to have you here. Thanks for coming. Welcome to the Alamo chapter of the Texas Academy of Family Physicians. So as Nancy pointed out, I'm Mark Nadeau. I'm the residency director for the Family Medicine Residency at the university. I'm going to discuss migraine headaches tonight, which is really one of my favorite topics, right? So, a lot of people don't like to deal with chronic pain, right? So you treat the patients, they don't get better, but this is different. It's way different. Like these patients, you can make them better, right? It's very gratifying. I think if you use some of the tools, well, I've been saying this for 30 years before we had some of the innovations that have occurred during my career. So I'm going to cover some of that. Before I move to the second slide, I want to point out on this slide, I have some headache art, right? So in the 1980s, who was the president? Ronald Reagan was the president, right? And the vice president was George H.W. Bush. I went to a conference and somebody had these, one of the displayers had these, the drug reps had a bunch of these different headache art things. And so I had asked for permission to use them. And so I think it really portrays the feeling that people get when they actually have these headaches, right? So this is a way that people express their feeling in art. So I think it's really super, heartfelt art when you look at that, because it's a person's lived experience. I know that there are a number of members of this academy that are very interested in art. So I thought it'd be appropriate to add that and talk about that a little bit. Actually, I've got a link on here, which I didn't test because there was a little bit of fog and friction, right? Getting all of that's the Air Force term, a little bit of fog and friction with getting all the stuff going. So I'm going to show you the link. Like I said, the panels that I'm going to put up were from the 80s, right? So, but there's been a lot since then. I'm not a headache sufferer. I've personally had one really bad headache in my life. But just looking at the size of the room, I am going to bet you that there's people in here that have migraine headaches, right? And so it's an extremely common problem. And so I think if you're not a migraine sufferer, you might find some education in looking at the art. So this is what the objectives are going to introduce migraine art. You guys already did that. One's accomplished. We're going to discuss the International Classification of Headache Disorders, discuss the diagnosis and treatment of migraine headaches. We're going to discuss the update and care of migraines that have occurred over the last several decades. And then we're going to finish on time, right? So, so we're going to try to do all of that. So if I get close, I'm going to expect some help from the audience in terms of nonverbals or maybe some verbals to help keep us on time. So there is one link to a bunch of headache art, but I don't think you need to write it down. I think if you go to any search engine and Google migraine art, you'll see like dozens of different offerings since the 80s. None of those are in this talk, but it is really very, very enlightening from my point of view. And then there's somebody put that together in a hardcover book. I think that would be interesting to look at. I'm not sure that's the perfect coffee table book, but it would be, but it is great, great art. Introduction, classification. We're going to go through all of these things that are written on the slide. I won't read them to you, right? So here's another piece of headache art. I just want to make the major point from the slide is this is a common problem. Like 12% of the population, 3-to-1, women and men. If you go do a literature search and read all the literature on it, you're going to find a study that's got slightly different numbers. But these numbers occur over and over again, or numbers in this neighborhood over and over again, like 18% of women, 6% of men. It's just extremely common, right? And it's extremely disabling when people have headaches. Not everyone, but a lot of people. It is a common reason for people to miss work. It is debilitating. It causes an impairment. People miss work. It disrupts lives. It can be a very big problem for a patient, and it is treatable. I'm going to make the point it's underdiagnosed in some senses. There's people walking around that have not been diagnosed, but you're going to find them, right? But this, in some senses, it's overdiagnosed, right? So I'm going to say it now rather than during the evaluation section. But when somebody comes into your office and they got a history of migraine headaches, my recommendation is go through that again, right? The patient comes in, they tell some doctor that, hey, I got migraine headaches, and they're in there for some other problem, and they write migraine headaches on the chart, and then forevermore, the person has migraine headaches, right? But in terms of efficacy of treatment, if you've got to believe in your heart that they actually have migraine headaches, the reason to make a difference is because the choice of how you treat them is way different. The algorithm is different, and you'll have more success, I think, if you sort of follow the diagnostic algorithm. So I hope I'm sounding a little forceful because I really feel strongly that you can make a big difference with knowledge of this stuff. So there's been many major breakthroughs in treatment of headaches in general, migraine headaches in the last 40 years, right? The biggest one was the development of the International Classification of Headache Disorders, right? So when I was a resident, this thing did not exist. It was not a thing, right? And so I did a grand rounds on migraines when I was a third-year resident, so that was 1984 or 5. And if you read the literature then about migraine headaches, you go read it. You'd have to read the methods section, right? So who is in the cadre of patients that they're studying, right? What's their definition? Because it was really all over the board. So can I apply this to my patients? I don't know. You got to read the methods section, right? So in 1988, they developed this. It's not dissimilar to the DSM, which I think is a little bit better known, but it's sort of like, like a la carte menu, right? You pick one of these, you go down the different sections. And if they got 2 of these and 1 of these, they meet the diagnostic criteria. And so the idea was to standardize the literature, standardize the research around headaches. So it wasn't just for migraines, this for all kinds of headaches. This thing's exhaustive. It's exhausting to read. If you're ever up at 2 in the morning and you're looking for something to fall back to sleep, this might be a place to start. It goes on and on and on, but I find it interesting, so keep me awake, but you might find that something that will put you to sleep, but very long, very detailed, but people started using it clinically. And so then you could feel confident in your clinical setting that you say somebody's got migraine headaches, that at least you're in the same cadre of patients that the articles are talking about. So extremely important. The other thing is the triptans, right? They did not exist when Ronald Reagan was president. They're new. They're really not more effective than the ergots or DHE, right? Which is a sort of a synthetic type of ergot, but the side effect profile is remarkably better. So they're much easier to use, can be used at home. So this has been revolutionary in terms of treating acute migraine headaches, right? Prophylactic agents, we've really learned a lot more since the early 80s. And so that's developed. And then there's some brand new agents that I'm going to mention at the end that I think are super interesting that I don't really have a lot of experience with. So they didn't just sit still, right? It's like everything else in medicine, right? So they decided, they tried it out for a while and they go, oh, we can make this better, right? So there've been new iterations, just like what do we use, the DSM-5, right? Well, when I was in medical school, it was the DSM-2, right? So it's changed over time and it's been updated. So like everything else, you gotta keep up with the times, right? I mean, how are they gonna think of new step 2 questions if they don't change the they just took step 2. So if they don't change the protocols, right? If they don't change the treatment algorithm. So this has changed over time. I think some upgrades. I think the important things related to migraine really didn't change that much since the first iteration, right? So it starts out pretty simple, right? Primary headaches and secondary headaches, right? So a secondary headache is, something else causes your headache. You get a hit on the head, that's a secondary headache, right? You get meningitis, that's a secondary headache, right? So I've got a list of those next, but the major primary headaches are listed here, right? They put migraine first, although I like putting it first because it's the most interesting one, but tension headaches is the most common one. That's like a shared experience, right? Who hadn't had a tension headache, right? And we'll cover the definition of that, although that's not the focus of the talk. But migraines, super common. Tension headaches, trigeminal autonomic cephalgias, like cluster headaches is the major part of that, right? And so that's the other thing. And then for something different there, other primary headaches. So that's a little imprecise. I've not seen too many charts that say other primary headache on it. So I'm not sure that's a particularly useful category, but that's what the classification currently says, right? Secondary headaches, like I said, I gave you a few of these, substance withdrawal, right? Infection, get hit on the head, psychiatric disorders, and et cetera, et cetera. A lot of things can cause a headache, right? And we're not going to focus on that on the talk too much, but just the idea that they made the simple thing at the, if you take somebody's head and you do an MRI and you do a bunch of other things, they're going to have normal studies, right? But it's something you can't see. So the headache is primary, right? So we're going to start with migraine without aura. It's more common, right? So I think people get the sense that, well, when they first introduce it in medical school, they talk about, let me talk about my medical school. At the University of Virginia, the first thing they said was, they talked about migraines with aura, which is very interesting. You get an aura, and then the aura lasts for how long? Not forever, right? Just less than an hour, right? 30 minutes is pretty typical, right? It's not like if somebody's got something going on for 3 hours, it's probably not an aura. Not 100%, but probably not an aura, right? So knowing the timetables, I think, helps you with your diagnostic acumen, right? So they get an aura, and then shortly after that, they get a headache, right? So what's the most common type of aura, right? I'll give you some choices: eyes, ears, stomach. Where's the aura? It's visual, right? So that's the most common thing, but it is very variable what you can get for auras, right? It is could be any type of neurologic phenomenon. Just most commonly, it is the eyes, and the scintillating scotomata. Easy, not easy to say, but very important thing to know, right? Okay, so back to migraine without aura. So there's different mnemonics. I think I've got one a little later in the slides, right? But just keep in mind, a migraine, they are, unilateral, pulsating, severe headaches associated with phonophobia, photophobia, and constitutional symptoms tend to run in families, right? So I don't know that you can make a mnemonic out of that, but that's what I remember. I don't use the pounds mnemonic or any other mnemonic, but if you're studying for your step, you may want to do the pounds mnemonic. But if they don't have that, if they don't have those elements or some of those elements, it may not be migraines, right? So a lot of people will come in and they'll say they have migraines, and then you start quizzing them about those things. They don't have them. So you need to feel deep in your heart that they actually have migraines, because then, or they don't. And then that really helps you decide which avenue you're going to go down in terms of care of the patient, right? So the migraine with aura, it's interesting. The criteria for migraine without aura is you got to have 5 headaches, right? The criteria for migraine with aura is 2 headaches, right? And I think that's fair because that's a lot more specific, right? They get the neurologic symptom, they get the headache, and then that has those certain characteristics. So if they got a couple of those, you can call them migraine headaches, right? You can write on your paper, well, it's clicks now, right? You can do clicks on your computer board to say they got migraine headaches with aura just after 2 headaches, right? Or with or without aura, it's 5, because the syndrome is less severe, but 1 headache doesn't get you the diagnosis, right? And then they've got to have some of these, right? Specific symptoms. I got the timetable in there, right? So an aura is not a 5-hour deal, right? It is a short deal. It's typically 30 minutes. The time frame, the step 2 question is 5 to 60 minutes, right? So it's a specific limited amount of time, right? And so there's just some categories, but to make one last point about migraines, I think before we go forward, is there's a limit to the time of migraine headaches, right? So how long does a migraine headache last? It's not a week, right? So typically it's less than a day, right? So it's a common story. Somebody come in and they got a headache and they fall asleep and they wake up and the headache's gone, right? That's not an unusual thing to happen at all, right? So you have to, if somebody's had a headache for a week, they may have migraines and have mixed type headaches, but that is the typical thing for migraines, is not that they have a headache for a week, right? So I think the timeframes are really helpful diagnostically, right? They run in families. Do migraines run in families? You bet they do, right? If somebody comes in and I'm taking the history, they got the pulsating, severe headache, et cetera, that I talked about before. If they've got no family history of migraines, it's kind of a point against them having migraines. It's not, oh, nobody in your family has it, you don't have migraines. But I think it's really helpful to take that. I think that's just a strong point in favor of having migraines, right? I'm not going to dwell too much on this. If you just look through the classification, there's all these different, classifications. They get pretty specific. I mean, I think for our practice, mostly it's, migraine headaches with and without aura. There are different kinds of aura, and these are just sub-classifications of some of that. And if you look at the classifications, it just gives you the point. Migraines can have a wide variety of neurologic symptoms, aura symptoms, right? All right. Tension headaches, bilateral, although migraines can be bilateral too, right? If they're unilateral, it's probably not tension headaches, but migraine headaches can be bilateral too. But it's not typically as severe. It's not associated with the photophobia, aura. So that's, and then they can have a different duration. It's a different duration, right? So somebody has a headache for 7 days, that could be a tension headache. It's just less likely a migraine. Of course, to make your life more complicated, I mean, this may be not a board question, but if people have mixed headaches, mixed type headaches, right? They can have one type, they can have the other type. I've always kind of thought, if you got a migraine headache, your head hurts so bad that sometimes that'll get you a tension headache too. I don't know. That's just my theory. And no photophobia, I already said that. Okay, there we go. So there's not some more headache art. So what causes migraine headaches, right? So when I was a resident, it was the vascular theory of migraines, right? So that's debunked. It's not a vascular phenomenon. It's a neurologic phenomenon, right? So that was, I think, a huge revelation, helpful in some of the development of the understanding of the disease. So all of the vascular changes are basically secondary, right? So the primary thing is the neurologic event. And one of the biggest factors, I think, that really, if you watch the spread on certain brain scans, it spreads at the same rate as other neurologic phenomenon, right? So it's a neurologic event. And they've known that since 2004. So president was Bush, right? George W. Bush, the second one, right? Okay. So there's some, the language here is pretty vague, right? There's some neuronal dysfunction, right? There's activation of the trigeminal nerve. There's this substance P. The blood-brain barrier is a little bit permeable, right? Messes up the ion channels, blah, blah. So still this many years later, there's not a keen understanding of the exact neurologic events, but just to make the point, for those of you trained back in the day, it's not a vascular phenomenon, although there are vascular events. If you give a talk about pathophysiology, you got to have a colored slide, right? It's got to have pictures of some cells and some neurotransmitters on that. So that's the obligatory slide. But that just basically makes the point that I was just making, right? So more headache art. So how do you evaluate this, right? So they don't have any. Your tests are going to be negative, right? You're going to scan their head, you can do your exam, it's going to be negative, right? They should have a negative neurologic exam. I mean, unless, of course, they don't have a negative neurologic exam, right? A patient who's in their 60s has had migraines since they were in their 20s and they've had a stroke. Well, they're not going to have a normal neurologic exam, right? That doesn't mean they're not having a migraine, right? So you have to be smart about it, right? Do you image everybody? Do you image these people or do you don't image these people? Does everybody have a migraine need a scan? No, right? So if you have somebody in front of you, they're having a migraine headache, and it's a pretty typical scenario, right? And they got a normal neurologic exam, then you're gonna, you don't need to scan their head. There's lots of studies that show that you're not gonna miss something major. Very unlikely. I mean, nobody can say never say never, but I think that's a very safe thing to do if they got a normal neurologic exam, right? If they fit the pattern, right? So migraines is a disease of young people or old people? Young people, right? So if you got somebody, a young woman, she's 18, she's got a new headache, she's in your ER, she got a normal neurologic exam, she got the splitting headache, she's got a phonophobia and photophobia, you're not going to image her head probably, right? On the other hand, if you've got somebody who's 50, I don't know, new headache, I'm imaging his head, right? I don't know. There's just too many other things it could be. That is just not the usual history. So I would have a low threshold in different settings for whether you image them, but you don't need to image everybody. Given the way people present, a lot of people don't really ever need imaging, right? If they go to a lot of ERs, they'll get a CT because they have one. But and if they actually get the CT, I would make the point, you might as well use it to your best advantage, right? Because people that have a headache this bad, they think there's something bad wrong in their head, a lot of them, right? That's a normal thought, right? So like the first thing I'll say is I looked at your CAT scan and there's no tumor. There's not, people think they got a cancer in their head. They do. It's amazing that, so if you got a scan, even if you wouldn't have got it yourself, I mean, use it to your best advantage. It may have some benefit, right? So what's the best scan? CT, MRI, both? So if they go to the ER, they're getting a CT because they're looking for a bleed, they're looking for something acute, right? And they've got a CT and the scan time is fast, right? So if you're in the clinic and it's a little more relaxed situation, right? You're going to see a smaller tumor with an MRI, right? So you're going to go that way. So it depends on the situation, what scan you get. I've never seen a situation where, you know, somebody come in with a migraine headache, they got a CT in the ER and they missed this tiny little tumor that was causing, I mean, I think that's a pretty far-fetched scenario. So I think if you got a normal CT, yeah, that's pretty good. But if you're a medical student or resident on rounds and somebody wants to pimp you, they might ask you about, yeah, but couldn't they have a small tumor small enough that they couldn't see it on the CT? And the answer is yes, indeed. But I've just never seen that. 40 years of doing a lot of this. Oh, I hit the wrong slide. All right. So those of you, I just found out the second years just took their step. So this is too late, right? And then the third years, they've taken their board. So if there's any third years there. But there's the PALS mnemonic, right? I don't find it particularly helpful. I use the other sort of, you know, severe pulsating, you know, headache that I told you about before. But this is a common mnemonic, right? So if you are in the mnemonics and you're studying for your step or you're studying for your boards, this is in a lot of the textbooks. So I put it in the slide deck. Not a big fan, but hey, there it is. Okay. Uh-oh, stopped advancing. All right. There we go. Okay. So red flags, right? So if the person comes in and they're young and they're healthy and there are no other diseases and they got a normal neurologic exam, you're not going to scan their head. But, you know, if they've got, you know, the worst headache they ever had, sudden severe onset, worsening pattern, that's not migraines. That's not what I've been talking about up here for 20 minutes at all, right? So there's bad things that can give you a headache, right? So if they don't fit the pattern, you know, follow the pattern, right? So I wouldn't have a huge huge worry about ordering scans or extra tests on other situations, right? So, I mean, obviously preeclampsia can give you a bad headache, right? Cancer in your head can give you a headache. So a lot of these are bad, right? If they Valsalva and the headache's worse, well, maybe their intracranial pressure is kind of close to the threshold, right? So there's a list of things, but mostly I don't think you need to memorize this list. I mean, mostly I think if they fit the pattern, a migraine headache, then I think you can feel pretty comfortable if they got a good neurologic exam. Uh-oh. So we already talked about that. Hey, we're in the middle of the opioid crisis, right? So I think you need to keep in mind, you know, judicious use of opioids. I can tell you, if you've got somebody who's having one severe headache, their first only severe headache, and you give them opioids, it's going to help, right? They're very good drugs for acute pain, right? I don't think it's a great pattern to get into for someone with a lot of chronic pain of really any type, because the way the body modulates pain, I think it stops working when people have more chronic pain, stops working as well. And then also you've got usage issues, but I don't have a big concern about using an occasional dose of opioids in somebody with a headache. Although you'll read articles, they tell you like, oh, you're a bad doctor if you do that. But I mean, I think you got to be real judicious. I think the opioid crisis has really, you know, taught us a lot, but But I will say for acute pain, it's effective. And this will be another example of that if you get yourself pushed for that. Do not recommend prolonged or frequent use of over-the-counter pain meds for headache. Why not? What? I don't know. Yeah, it's because they get medication headaches, right? So I know I used to have a much cooler name back when Reagan was president. It's called Drug-Induced Refractory Headaches, right? I don't know what the current term is. I don't remember because I just like that one. It sounds good, but it's the same thing, right? That if somebody's got headache pain and they're taking chronic over-the-counter pain medicines, NSAIDs, Tylenol, opioids, Fioricet, they can develop this headache pattern where they have a chronic headache all the time, right? And so they've got sort of a medication overuse headache, right? It's not rare. Check for it. It's not uncommon, right? And so people get in that pattern and they'll come to you and they'll already be in the pattern, right? They'll have been buying and, Motrin over the counter, Tylenol, and taking that every day. And so this is not, and it's not an easy problem to solve. So, so just keep that in mind. Don't be part of developing that. Sometimes you have to work people out of that. It actually can be it can be gratifying if you can solve the problem, but that can actually be a very challenging problem. Risk factors like avoid triggers, right? So somebody, like if I eat this, I get a headache, right? Guy goes to the doctor, says, it hurts when I do this. The doctor says, don't do that, right? So I'm going to make the point. I mean, maybe in your hands, like a dietary history for migraines has been pretty effective. I've not had much success with that over the years, right? There are people that say, oh, I eat chocolate, but there's a lot of people telling people not to eat chocolate, which is not a great idea unless you got a really good reason not to eat chocolate. But most people don't have dietary. Okay, it's a bias, but most people don't have diet, but there are some people that do. So I think if you tried a couple things, you're not working that, it's not working. I think that's a reasonable avenue. I'm not discounting it. I'm just saying in my hands, I've not say, oh, I got all these migraine patients better by taking them off, caffeine or chocolate or some other thing that's fun to do, right? Birth control pills, right? So birth control pills, that's to me, I think that is a serious issue, right? Women who have migraines, a lot of them, not all of them, but a lot of them, the migraines will get worse if you put them on birth control pills, right? Some sort of estrogen sensitive thing associated with migraines. And since they don't understand the pathophysiology, how could they understand exactly the interaction? But I don't think that's I think that is an issue. So, and some people will say that you put them at risk for, serious neurologic injury. I've read that in my whole career, 40 years I've been reading that. And I've never seen that, but that is a thing you'll read. So I think I'd try to steer away generally from estrogen-based contraception for somebody who you believe in your heart really has migraines. So you see why I go back to, you got to think really deeply, like this is what they have, right? If it's tension headaches, you're kind of throwing away a pretty valuable, part of your medical armamentarium, right? So anybody with headaches, I don't give them birth control pills. I don't know. That's a lot of people, right? Who doesn't have headaches? So I think that's really important just from a practical standpoint to figure that out. And then but I do believe that, avoiding estrogens is probably helpful in a lot of patients, probably most patients. Behavioral stress, fatigue, environmental, loud noise. I don't know. I've never seen anybody who I thought pollution caused their migraines, but there you have it. It's almost like, as far as the stress goes, headaches can be stress related. Migraines can be induced by stress. It's kind of interesting. Sometimes it's like they'll have a stressor, and that's not when they get the headache, right? They get the stressor when the stress is relieved, right? So the classic story is, I got some college student and she's studying for these finals and she does fine through finals and then finishes her last final and then she gets a huge headache the next day. That's sort of the illustrative story, but that's not a rare pattern. People get it after a major stress event. So again, I talked about when you treat the patient. We're going to talk about drugs in a minute here, but actually, I really think the first thing is I mean, the patient wants reassurance, right? They want to believe you know what's going on with them. And I've been impressed over the years at how many people, they think they got something really bad wrong in their head, right? So, reassuring them that they don't, using the findings of whatever a scan, if you got one, to sort of reemphasize that they don't have a bleed or a tumor or something bad going on inside their head. I think that's been really helpful in my practice. Pain relief and Anionics, right? A lot of people get, nausea and vomiting with this. So just sort of keep that in mind, right? There's a list of things there. By the time they get to you, they probably tried the first two, right? The triptans, I think, are incredibly revolutionized the care of outpatient migraines. Really, really been a very important part of the care. A lot of people that, I mean, even if they get the migraine, it saves them a trip to the ER, right? So going to the ER is not a pleasant experience for any of you who've joined us there, right? So, so I think that is hugely beneficial for patients that are having not terribly frequent migraines, but even frequent migraines. Sometimes you can really improve their pattern, make them more functional. Because as we said early on, this can be a very debilitating problem, right? DHE 45, I put that in as a, again, as another sort of salute to Ronald Reagan. That was the go-to back in the day, right? It really works. It's really nearly about as effective as the triptans, but the side effect profile is really much worse, right? I don't think it's, I don't know. People talk about like totally unsafe. We used to use it all the time because that's what we had. But it does need to be monitored. And so we sort of had it, clinics I worked in back in the day. We would, we had a protocol. We'd set them up, put IV in them, monitor them a certain way, and it was fine. It worked out good. And we never really had anybody have a serious complication of that. Used it a lot. It is really effective, like the triptans. It's just much harder to use. And then we talked about Anionics already. Daggone it. There we go. Okay. So the triptans, pick one, right? So there is, if you use one, it doesn't work, you can try another one. Like a lot of drugs, that does happen. But I can't say, oh, this one's more effective than that one, right? So the first one you choose is the one their insurance will pay for, right? And so they've been around a long time. A lot of people are on them. I've ordered them a bunch of times. I think I've had patients say they've had side effects with them, but really nothing that, the side effect took them back to the doctor's office, or the side effect took them back to the ER. Has anybody ever had that? Yeah. But then I've not had that a lot. Okay. Okay. Interesting. Okay. I've not really had a lot of that. So anxiety and chest pain is what I've heard from the audience here. So okay. Thanks. Appreciate the insight on that. So, but now there's some new stuff, right? Now I'm not used to this stuff, right? I was reading about this talk. They asked me to do the talk. I go, like, what's the new stuff, right? So there's the ditans, right? And there's a name that I'm not even sure how to pronounce that. It's new, but it's a selective 1F receptor agonist. I don't think that's going to be on the step just yet, right? But soon, like maybe by the time you guys are taking your boards, it'll be on there, right? In 5 years or so, right? So they're coming too. And by 5 years from now, they'll be asking you on a selective F1 receptor agonist for treatment of migraines, right? And the triptans, right? So these are calcitonin gene-related peptide antagonists. I actually think that's a fair question now, right? So you might get asked that in the not too distant future on a high stakes exam. And some of the new therapies, the monoclonal antibody therapies, are aiming at that receptor, right? So I think if you want to take home something that's going to be, I think, a great, great for like roundsmanship, right? So if you guys have a medical student tomorrow, you want to pimp them, right? There's a great pimp question, right? Or if you guys want to impress your friends, right? I went to this dinner and they taught us about calcitonin gene-related peptide, right? So I think that's a long-term thing. I think that is the new thing. I think a lot of these therapies will point exactly at that. Remember, you heard it here first. Well, maybe you didn't hear it here first, but at least I emphasized it for you so you'll get the question right in the future, right? So just read the package insert. I mean, they don't have package inserts anymore. Look it up to date and then do that, right? So we're family physicians. We see patients in a lot of different settings, right? So what works in pregnancy? Guess what? You can't use most of this stuff, right? So it's not, a lot of that stuff's not safe in pregnancy, right? So it's limited. So a patient with pregnancy migraines, I don't know. I've not taken care of too many, but I'll bet it's hard. Anybody done a lot of that? Any of you folks done a lot of that? Yeah. So I've not, but all right. Lactation, but we do that a lot too, right? Get the patient, they delivered, they got a baby. There's not that much, right? So just to make the point, if you got a patient who's pregnant or they're lactating, you got to look it up, right? And decide what you're going to give. I don't think you need to memorize the list, right? So is droperidol on that list or not, right? Just that's a great question for roundsmanship, but I don't think you need from a clinical basis to really know that. You can look up, I'm going to start this, I'm going to do something, and you can look these things up. All right. So preventive therapies, this is super interesting to me, right? So back in the day, when in the 80s, it was beta blockers was the big thing in the US, and they're pretty effective, right? But in Europe, amitriptyline was the big thing back then, right? And I actually think it's more effective. There's a variety of different things. I don't think I've not had much success with the angiotensin II receptor blockers or with, but I do think the topiramate, the sort of the anti-epileptics and valproate, I've had good success with those, right? So the things I go to first are Elavil, propranolol, because of the side effect profile, topiramate, and then valproate. That's what I go. That's my go-tos. But here's sort of the textbook answer, right? There's other things on the list, and I would say a lot of people, well, back in those days, we didn't have the new antidepressants, right? So we used amitriptyline a lot, right? And there was side effect profile wasn't that great, but you can get success with migraine prophylaxis well below what used to be considered therapeutic doses for depression. So you really end up on smaller doses, over 100 or 150 or something for some of the old antidepressants, but you have good success, people on 50 and 25 milligrams. So the side effect profile has been better for migraine prophylaxis, especially for amitriptyline, in my view, because you use lower doses, and have had good success with that. And then there you go. This is the new stuff. I've not used any of this stuff, right? I've not used any botulinum toxin or any of these new monoclonal antibodies, right? The CGRPs, right? That you guys are going to be, sort of, pimping your friends about later on to show your superb roundsmanship, right? But those are the new thing, and I'm really excited to learn more about those. I see them clinically in action, but there are some new. But they're there because they're working. Like there's patients that have had refractory headaches that haven't been improved. And so while I'll say the situation improved from when I was a resident, over the next 20 years, it continues to improve, right? So to get back to one of my major points is, even though it's chronic pain, you can get a lot of these patients better. You can make their headaches either less. You can make their headaches either less, that's good. Either less severe, or you make their headaches less frequent. And either one of those really makes the patient's quality of life way better, right? Oh, I'm still good. Okay. So evidence is conflicting, right? So gabapentin, not a big fan. Fluoxetine, calcium channel blockers when they came out in the 80s again, right? So we'll trip down a little history lesson here, right? So there was a lot of enthusiasm. These might be great prophylactic agents, right? And none of that panned out, right? So these are much less effective, but it's all individualized, right? So if you've not had success with some of the others, you could try some of these. Some people will tell you that they've had success with these, but these are significantly further down the list. But if you combine this with the list that really shows that the things that have worked pretty good, it's a pretty long list, right? You got a bunch of stuff you can try, right? Chris. It's not, yeah, that's right. So yeah, we were really thought this might really work, might be great. What a bust, right? So I wouldn't recommend that. I'd probably use all the others before I used the 2 calcium channel blockers on there. I'd probably even use gabapentin before I use the calcium channel blockers. Okay, I'm not good with this. Okay, if you're like in a non prescribable type medications, feverfew, magnesium, riboflavin. I don't know. I've not used that at all, but this is supposed to be comprehensive talk. So there it is. Some people use that stuff, not for me. But I would say some of these relaxation therapies and cognitive behavioral therapy, some of the sort of the trance approaches. So to me, there's a lot of commonality between some of those trance approaches. And so I think a number of people will try some of those things on their own, meditation and other type things like that, and have good success with that. So while I'm not a big fan of the feverfew choice, those other two may give you some excellent improvement in your patient. We talked about birth control to some extent, right? And just with the caution, a lot of people's headaches are estrogen sensitive. And so you may actually make their headaches worse. And again, if you read a bunch about headaches, there'll be some scare stories about somebody's had this. I've never seen that, but hey, I'm scared by the stories, right? So I wouldn't really stay away from estrogen-based contraception. But in this day and age, of course, we have a lot of choices, right? So doesn't mean the patient doesn't get contraception. It just means you don't give them the standard birth control pills, right? So now we get to the summary. I'm going to finish on time, right? So there you go. So I at least accomplished that objective, and hopefully most of the others. So in summary, this is a very interesting and satisfying problem to treat, right? You can make a big difference. It is not frustrating like a lot of chronic pain issues are. It is really fun because you can get a lot of people a lot better. If you start out with realistic expectations with the patients, right? Just like that, right? Like if their goal is they're going to never have another migraine again, you're going to fail, right? But if your goal is to get them more functional, if your goal is to get them fewer headaches, less severe headaches, you are likely, very likely to have some success with that and to improve their life like a lot. And even if you don't improve it much, I think if you've got the reassurance there's not something really bad wrong inside their head, you've given them something. So there's really a lot of ways to help, patients with this problem, which is why I think it's a very interesting problem and fun to treat. And we talked about diagnosis and treatment, and I guess I've got time for questions. Question? Mm-hmm. Mm-hmm. That is a great question. I'm going to go look that up tomorrow. So no, that's super interesting, right? So as far as preparing for this, I didn't see, COVID jump out, but you're right. There's a whole, huge list of different symptoms people have had, and people had symptoms with long COVID, some of which are headache syndromes. I've not specifically read about migraines, but maybe somebody else has. I can't tell you. Chris. I don't know. I mean, so to me, it's a neurologic phenomenon, right? And COVID is in your brain, right? I mean, it is a neurologic, I mean, it's in there, right? That's why you can't smell, right? So it does affect the neurologic processes somehow, certainly your smell. But I've not read that. That's a super interesting question. Thank you. It improves the vaccination, the headaches. Oh. Okay, so for those on the call, if there's anybody still there, the neurologic symptoms have improved with in a lot of patients with the vaccination. All right, that's super interesting. I think we're still going to keep learning about long COVID, and maybe we're going to and we're going to learn about migraines. At least I am. So that's great. Question. What's my spiel? Well, I will, once I've established that they have migraines and that they have it in a sense, in a way that and they have the wherewithal to actually have the medicine available and take it and monitor the side effects but themselves, which is kind of a low bar. Then, so I'll just tell them, you could get this side effects. A lot of times I'll, pull it up on UpToDate, which is, say it says here, and then we'll kind of go through that and then tell them, this is how you take it. And I'll kind of go the dosing and tell them, when to take it and when in the headache sequence to take it. And, so pretty deliberate. I'm not sure I didn't do anything particularly special other than kind of going through what used to be called the package insert. Now it's, it's just the drug information. Did you have a specific recommendation? Yeah, it's all, so it's all in there on the prescribing information, and you write that in your SIG. It's not exactly the same for each of the triptans, but there's a certain number a day and certain time sequences and stuff. So yes, so I just tell them and put that in the SIG about, you take it, and if you don't have it, you can take it, a certain interval. So it's all explained I just follow the SIG, just follow the manufacturer's recommendation for how to prescribe it. And that's exactly what I tell them. Yeah. Okay, so for folks on the call, the question was, if you have somebody who really doesn't want to take birth control pills and you don't want to put them on that because they got migraines, but would you consider lower dose estrogen modalities as opposed to because there might be less risk on lower doses? Is that? So I've not seen that fleshed out. That's a great question. To me, the caution is about use of estrogen, right? So if they have a complication, you gave it to them, right? And so I think, just from a protecting yourself standpoint, I generally don't. Having said that, somebody may be able to say, oh, there's this great study on low dose estrogen, but I'm not aware of any of that. I don't do it. If I think they got, deep in my heart, I think they got migraines, I'm going to stay away from the estrogens that I give them. That's my approach. I certainly not seen anything to convince me that low dose is okay, or that, that the plaintiff's attorney wouldn't be asking you about your use of estrogen, say, in that patient if they had a problem. Right. I mean, and I think it's fine. It's like, I'm not doing that. I don't think it's safe. Right. I mean, I think that it's to some extent there's a negotiation with the patient, but not everything's negotiable. Right. So I'm not doing that. I don't think it's safe, but we got these other options. Right. And they don't have to choose your option. Right. So that's kind of how. Right. Right. Yeah. Yeah. There's no estrogen in there. That'd be a good option. That's a good way to start if they want to think about it, like they want something. The LARCs, like the Nexplanon, that sort of thing. Yeah. Right. Yeah. So I don't know. You just got to work with the patient, but I think, I don't know. I mean, I think there's a pretty clear caution that has been pretty standard for like at least 40 years, right? And they say, estrogens, there's some risk to it, right? So, I'm not doing it, right? So you just got to do what you think is best, but so you don't have to do it if they don't, even if they want it, you don't have to do it, right? So when the hormone balance changes, some people's migraines will change. Some will get better because they have less estrogen. But of course, like everything else, some will get worse. So yeah. Huh? Mhm. So, so before, if somebody never had migraines, and I'm thinking this 50-year-old person, I think that's a migraine. I don't know. I'm going to do a pretty good workup before I decide, okay, that's migraines, just because that's not the usual history, right? That's a primary headache. New onset headaches after 50, that's pretty scary stuff, right? So, once you've worked them up, and if you have, I've not had this, but if you have a patient who they're 50 and they're postmenopausal, and I worked them up and scanned their head, and I think they got migraines because the history is really, really good. So I'm not sure why you couldn't use the standard approach, the standard medications, but I've not done a lot of that. Mhm. So, yeah. Well, it's on the list, right? So some people have had success with that. I'm not sure I've read that it's more effective in older patients. But I've had a lot of success with prophylaxis, prophylacting patients. And there's some differences of opinion about how frequently do you use prophylaxis, right? So when do you give patients prophylaxis, right? I mean, when they get 4 headaches a month, 2 headaches a month, 1 headache a month, 1 headache every other month, what's the threshold, right? So there's differences of opinion about that. I'm fairly assertive, right? If they have less than 2 a month, then you got to kind of treat them, prophylax them for a while before you really can tell, a couple of cycles, right? A couple of months anyway, you can tell if it's having any effect at all, right? 2 or 3 months, right? But if they're having 2 a month and they find it debilitating, I think that's worth trying. Once it gets less than once a month, I'm a little less enthusiastic, but I could see doing it if you really, but that would be a shared decision-making thing. That's kind of my cutoff. I usually don't sort of push for prophylaxis for less than once a month, but I think you could individualize that a little bit. If they were having 1 headache or 2 headaches a year, I don't think I'd prophylax that, right? So you got to decide. There's no 100% agreed upon cutoff for what the number is. And I think it partly, depends on if the headaches are really, really bad, really debilitating, let's try it. And I've had some success with people with less frequent headaches once a month that's really helped them. So that I've had a fair experience with. Aren't they going to feed you guys? Oh. Yep.
Thank you. You can go this way.
Right.
Okay, so thank you, Dr. Nadeau. And I think we were checking and there were no questions on the chat. So for the item number 5, reports from officers, we don't have any report this month. And these take us to item 7. And if no any Special announcements. Our next meeting is going to be Tuesday, June 28th, and it's going to be our resident scholarly activity. So we are inviting to the residency programs to please contact us and let us know which scholarly activity are your residents wanting to present. So the name and the topic, and we will coordinate that. So that's what we will do. We will not have a Zoom session for that and no CME credit, but that will be our session next month. Does anyone have any questions, or we can adjourn the meeting? Yes.
So just a pitch for next month. That's really been one of our most fun and well-attended meetings of the year. So when you folks go back to Christus, tell them, like it should be fun. And like last year, we had a bunch of posters here and a bunch of people, and it was really pretty lively and fun. So look forward to seeing everybody there. Just a plug. Sorry.
Yeah, perfect. Any questions? Yes. Yeah, let me see if I can go back there. You mean to register, correct? We checked and there were no questions in the chat. Okay, so the meeting then is adjourned. Thank you. Huh?